What is going on, wonderful people? It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my neurology playlist. In previous videos, we talked about strokes, ischemic and hemorrhagic. We talked about the types of shock, including neurogenic shock. We discussed amyotrophic lateral sclerosis, or ALS. We talked about upper motor neuron lesion and lower motor neuron lesion. Talked about Horner syndrome, multiple sclerosis, and Guillain-Barré syndrome, myasthenia gravis, and Lambert-Eaton myasthenic syndrome. We had lectures on vertigo, labyrinthitis, and Meniere's disease. We had videos on sleep and sleep disorders, including insomnia, hypersomnia, REM sleep disorders, narcolepsy, and restless leg syndrome. Today, we turn our attention to pituitary adenoma. What does OMA mean? Tumor. In medicine, any word that ends in OMA is a tumor, except for Oklahoma. And what does adeno mean? It means a gland. Which gland are we talking about? The pituitary gland. Click the like button, click the subscribe button, and let's get started. I have several neuro playlists on this channel. The first is called Neuroanatomy. I have one called Neurophysiology, and the most comprehensive one is called Neurology, which includes neuroanatomy, neurophysiology, neuropharmacology, and neuropathology. Types of cellular growth. There is hypertrophy, there is hyperplasia, there is metaplasia, dysplasia, and neoplasia. But what does aplasia mean? The word plasia means growth and a means no. So aplasia means no growth. How about atrophy? It's similar, no growth. What does hypertrophy mean? It means increased size of cell. Hyperplasia, increased number of cells. Metaplasia, change from one tissue type to another tissue type within the same category, from epithelium to another epithelium, or from connective tissue to another connective tissue. Next, dysplasia. Dys means dysfunction or difficulty or defective, and plasia means growth, but meta means change. How about neo? Neo means new. Oh, new growth. This is what we call a tumor. So tumor equals neoplasia equals any word that ends in oma. And we divide these tumors or neoplasias into benign tumors and malignant tumors. Malignant tumors are also known as cancers. If I say the word adenoma, this is a tumor in glands, and this is benign. If you want to make the word malignant, say adenocarcinoma. So when you say carcinoma or sarcoma, it becomes malignant. For example, papilloma, benign. Papillary carcinoma, malignant. Lipoma, benign. Liposarcoma, malignant. Chondroma, benign. Chondrosarcoma, malignant. Osteoma, benign. Osteosarcoma, malignant. Leiomyoma, benign. Leiomyosarcoma, malignant. Today we're talking about pituitary adenoma, benign. But if we say adenocarcinoma, then it's malignant. You have no idea how many doofuses with stethoscopes running around who have never grasped these basic concepts. No wonder why patients are not satisfied with their doctors. What is a neoplasia? What is a tumor? What is an OMA? It's an abnormal mass of tissue. Okay. Whose growth exceeds and is uncoordinated with that of normal tissue. We cannot say the same thing about hyperplasia. Hyperplasia does not exceed and is uncoordinated with that of normal tissue. Hyperplasia does not persist even after you remove the stimulus. But neoplasias do persist even after the original stimulus is no longer there. For example, suppose that I smoked and smoked and smoked and smoked and smoked until I developed small cell lung cancer. If I stop smoking today, do you think that the small cell lung cancer will simply leave the chat? Nuh-uh, it's not gonna happen, because neoplasias persist even after cessation of the original stimulus that caused the growth in the first place. If you wish to see more videos like this in the future, please drop a brain emoji in the comments. Tumors or neoplasias or any word that ends in oma include benign and malignant. Benign tumors never metastasize. For example, today we're talking about pituitary adenoma. This is a benign tumor that never metastasizes. But malignant tumors or cancers can metastasize. We divide malignant tumors or cancers into cancers of the epithelium or carcinomas and cancers of the connective tissue or sarcoma. Carcinomas tend to metastasize to lymph first, whereas sarcomas tend to metastasize to blood. To understand what the pituitary adenoma does, we first need to review some endocrine basics. This is the Chief Executive Officer, the hypothalamus, the CEO of Endocrine Inc. Under the CEO, we have the general manager, which is the anterior pituitary gland. If the hypothalamus secretes growth hormone releasing hormone, then the anterior pituitary will respond by secreting growth hormone, also known as somatotropins. So the cells in the pituitary that secrete somatotropin are called somatotrophs. But if the hypothalamus secretes somatostatin, then the anterior pituitary will secrete less growth hormone. If the hypothalamus secretes gonadotropin-releasing hormone, the anterior pituitary will respond by secreting the gonadotropins. These gonadotropins include FSH and LH, follicle-stimulating hormone and luteinizing hormone. To learn more about them, please review my reproductive system series in my physiology playlist. If the hypothalamus secretes TRH or thyrotropin-releasing hormone, the anterior pituitary will secrete thyrotropin, also known as TSH or thyroid-stimulating hormone. When the hypothalamus secretes CRH or corticotropin-releasing hormone, the anterior pituitary responds by secreting the corticotropin, which is ACTH, otherwise known as adrenocorticotropic hormone. If the hypothalamus secretes TRH, that's the same TRH as here, the anterior pituitary secretes more prolactin. But if the hypothalamus secretes dopamine, then the anterior pituitary secretes less prolactin. And that's why dopamine is known as the prolactin inhibiting factor, or the prolactin inhibiting hormone, because dopamine inhibits prolactin release. Now let's suppose that I have a pituitary adenoma. Some of the adenomas do not secrete, others do secrete. Let's suppose that this pituitary adenoma that I have is a secretory one. It can secrete growth hormone, and if I have too much growth hormone, I will develop acromegaly. And since I cannot grow taller anymore, I can grow thicker and larger. What if my pituitary gland secretes lots of gonadotropins? Then this can increase the secretions of sex hormones, testosterone in males and estrogen progesterone in females. If my pituitary adenoma secretes too much TSH, my thyroid gland will respond by secreting too much thyroid hormone. And if my pituitary gland secretes too much ACTH, my adrenal cortex will secrete too much cortisol and I will suffer from Cushing disease. If my pituitary gland secretes prolactin, which is the most common variant by the way, prolactinomas are the most common types of pituitary adenomas. Then females will develop galactorrhea and amenorrhea, whereas males tend to develop impotence and gynecomastia. And you can also add hypogonadism and decreased libido. If my pituitary adenoma secretes too much growth hormone, we call it somatotropinoma. If it secretes too much gonadotropins, we call it gonadotropinoma. But if my pituitary gland secretes too much TSH, we call it thyrotropinoma. And if it secretes too much ACTH, it is corticotropinoma. And if it secretes too much prolactin, it is indeed a prolactinoma. If you wish to download these doozy colorful notes, go to medicosisperfectionalis.com. I help you learn, understand, and pass exams. If you want me to personally tutor you, reach out to me on my website. We just said that dopamine is anti-prolactin. Is that right? Yes, indeed, because dopamine in the brain has different functions depending on the location. Dopamine in the nigrostriatal pathway is for movement. If you have too much dopamine there, you move a lot. If you have too little dopamine in the nigrostriatal pathway, you move little. You have a movement difficulty. But dopamine in the mesocorticolimbic pathway, or mesocortic and mesolimbic, is important for mood and reward. Too much dopamine here, I get too much mood, psychosis, euphoria, hallucinations. Too little dopamine, what's the purpose of life anyway? This is anhedonia. Third, dopamine in the tuberoinfundibular pathway. That's the story where dopamine is anti-prolactin. So therefore, too much dopamine, well, there will be no prolactin whatsoever. I'm going to inhibit prolactin. But too little dopamine, prolactin will be left uninhibited. To cause what? To cause hyperprolactinemia. And what's the problem with hyperprolactinemia? You get galactorrhea. What does rhea mean? Rhea from Rio means river, as in Rio de Janeiro, Rio Grande, etc. Galacto from galactose. Oh, milk. That's true. So galactorrhea means flow of milk from the nipples when the lady is not breastfeeding. Moreover, too much prolactin is going to inhibit the gonadotropin-releasing hormone, which will inhibit the release of FSH and LH. In females, this leads to amenorrhea. This leads to anovulation, infertility. If we do not have enough follicle-stimulating hormone, there will be No enough stimulation of the follicles. So the follicles will not grow and they will not secrete estrogen. And if there is no estrogen, the bones are sad, in a state of misery known as osteopenia. Less FSH and LH, less estrogen and progesterone, less vaginal lubrication, which can lead to painful intercourse, a condition known as dyspareunia. Low FSH and LH in males will lead to impotence, gynecomastia, because there is no testosterone anymore, infertility, hypogonadism, and decreased libido. Let me ask you a question. Suppose that we have two patients, one female and the other is male. Both of them suffer from prolactinoma, which secretes too much prolactin. The question is, which one of these two will notice the symptoms first? Is it the female or the male? Please comment below if you know the answer. And please explain your answer. If you have watched my neuroanatomy playlist, I've told you that cranial nerves 1 and 2 are attached to the forebrain. Cranial nerves number 3 and 4 are attached to the midbrain. Number 5, 6, 7, and 8 are attached to the pons, but cranial nerves 9, 10, 11, and 12 are attached to the medulla. Today we're talking about a pituitary adenoma. One thing that the pituitary adenoma can do is that it compresses the optic chiasm, which is in the visual pathway, which can lead to visual deficits. If you want to master anatomy, I have quick review videos on every subject in anatomy, such as the head and neck, upper limbs, lower limbs, thorax, abdomen, pelvis, perineum, neuroanatomy, and embryology. Each subject is reviewed in 2 videos, and you can watch them in my anatomy playlist. Let's review the anatomy of the optic nerve. This is your left eyeball, this is your right eyeball, this is the retina, this is the retina in the other eye. The retina has gazillion layers. One of them is the ganglion cell layers. The ganglion cell layer is the beginning of the optic nerve. The optic nerve is sensory, of course, so therefore it's afferent. It starts in the eyes and reaches the brain. So here's the left optic nerve and the right optic nerve. This is the optic chiasm where the 2 optic nerves meet. After the optic chiasm or optic chiasma or chiasmata, you have the optic tracts, one on the left, one on the right. After the optic tracts, we reach the thalamus in something called lateral geniculate body. You have one on the left and one on the right as well. After this, we go to the optic radiation. And after the optic radiation, we radiate into the visual cortex of the brain in the occipital lobe. This is called the visual pathway. But if I suffer from a pituitary adenoma, well, here's the silla turcica or the Turkish saddle. And here is the pituitary gland, and the pituitary gland is going to swell and swell and swell and swell and swell because it has an adenoma, it has a tumor. As the tumor grows and grows and grows, it's going to press on the optic chiasm, compressing it, leading to visual deficits, as we'll see. Here is an inferior view of the brain. This is the undersurface. Anterior is here, posterior is there. These are the frontal lobes, these are the temporal lobes, and these are the occipital lobes, and this is the doozy cerebellum. You see this? This is the hypophysis cerebri, otherwise known as the pituitary gland. And this is the optic chiasm between the right optic nerve and the left optic nerve. And therefore, if I develop a pituitary adenoma, it can grow and grow and grow until it compresses the central part of the optic chiasm, leading to visual deficits. But what kind of deficits? Well, to understand this, we need to go back to the visual pathway. I have a separate video titled The Visual Pathway and Its Deficits in my neuroanatomy playlist. Physiologically speaking, this is your left eye, this is your right eye. This is your left visual field, what you see by your left eye. And this is the right visual field, what you see by your right eye. Each visual field has part that's closer to your nose, we call this the nasal visual field, and part that is closer to your temples, temporal visual fields. Since light travels in straight lines, therefore the nasal visual field projects onto your temporal retina, and vice versa. The temporal visual field projects on the nasal retina, and that's also true for the other eye. Nasal field on temporal retina and temporal field on the nasal retina. Then the temporal retina will be continuous with the temporal fibers of the optic nerve, and the nasal retina will be continuous with the nasal fibers of the optic nerve. On the other eye, it's the same story. Nasal retina, nasal fibers, temporal retina, temporal fibers. Now something funny is going to happen at the optic chiasm. The temporal fibers, which are responsible for the nasal visual field, will continue as is on the same side. And that's also true for the other eye. The temporal fibers responsible for the nasal visual field will continue as is on the same side. But look at the nasal fibers, which control the temporal visual field. These nasal fibers do cross to the opposite side. The right crosses to the left and the left crosses to the right. Therefore, what do you think is going to happen if I develop a pituitary adenoma? It will compress the central part of the optic chiasm, destroying the nasal fibers and therefore the temporal fields. So I will lose both temporal fields, which means the temporal sides of the visual fields are blind to me. I cannot see anything temporally. And what do we call this? Well, since this happened on both eyes, I'm going to say bi, meaning two. The problem is in the temporal, not the nasal, so it's bitemporal. Did I lose all of the eye? No, just half. Okay, so hemi, which means half, and I cannot see anymore, so N, meaning no, and vision is opia. So it's called bitemporal hemianopia. Some people say bitemporal hemianopia, others say bitemporal hemianopsia. It's the exact same thing. To learn more about the other visual deficits, please refer to the video titled Visual Pathway and Visual Deficits in my neuroanatomy playlist. Pituitary adenomas classification depending on size. Some of them are smaller than 10 millimeters, so we call them microadenomas. If they are larger than 10, we call them macroadenomas. If the size is larger than 40 millimeters, this is a giant pituitary adenoma. Based on the function or the secretion, some of them are non-secretory, some of them are secretory. If they are non-secretory, that does not mean that everything is hunky-dory, because it's still a tumor, and the tumor occupies a space. So this can still compress the optic chiasm. How about the secretory? Of course, they occupy a space, but they do something else. They secrete. Secrete what? Well, some of them are somatostatinomas. They secrete somatostatin, also known as growth hormone, which can lead to acromegaly. Some of these pituitary adenomas are prolactinomas, which means that they secrete prolactin, which causes hyperprolactinemia and galactorrhea. If the pituitary adenoma is a corticotropinoma, it secretes corticotropin or ACTH, so the adrenal cortex will secrete too much cortisol and I will get Cushing disease. If the pituitary adenoma is a thyrotropinoma, it secretes thyrotropin or TSH. Now, the thyroid gland will secrete too much thyroid hormone, leading to hyperthyroidism. What are the symptoms of acromegaly? What are the symptoms of Cushing disease? What are the symptoms of hyperthyroidism? Please practice your knowledge by commenting below. The non-secretory pituitary adenomas constitute about 30%. The secretory pituitary adenomas are divided into somatostatinoma, 25%. Prolactinomas are the most common by far at 37%. Corticotropinoma, 7%. Thyrotropinoma, 1%. Pituitary adenomas and the local mass effect. This adenoma can compress the optic chiasm, leading to bitemporal hemianopia. It can compress the pituitary gland itself, leading to hypopituitarism. Sometimes it's even pan-hypopituitarism, where everything secreted from the pituitary decreases. So the growth hormone is low, TSH is low, ACTH is low, FSH is low, LH is low, prolactin is low, everything is low. Next, compression of the gonadotrophs in the pituitary can lead to hypogonadism or premenopause. The adenoma can keep growing and growing and growing until it extends into the cavernous sinus, leading to cavernous sinus syndrome and cranial nerve deficits. To learn more about the cavernous sinus and the cavernous sinus syndrome, please refer to my neuroanatomy playlist. I have a video titled The Cavernous Sinus. The pituitary adenoma can extend into the third ventricle, compressing the foramen of Monro, leading to hydrocephalus. Of course, you shall remember that the foramen of Monro is between the lateral ventricle, let's draw a lateral ventricle right here, nice, and the third ventricle like this. The foramen of Monro is right here, between the lateral ventricle and the third ventricle. So if there is compression at the foramen of Monro, lots of cerebrospinal fluid will accumulate in the lateral ventricle and it will swell and enlarge and enlarge. And this is called hydrocephalus. I have a video on hydrocephalus in my neurology playlist. The pituitary adenoma can compress the hypothalamus or the pituitary stalk. And if the pituitary stalk or the infundibulum gets compressed, what's going to happen? The posterior pituitary will suffer. And normally the posterior pituitary should secrete antidiuretic hormone. But now it does not secrete antidiuretic hormone. So I cannot retain water in my body. All of that water will be lost in the urine, diabetes insipidus. It's the urine that is insipid, i.e. tasteless. Why tasteless? Because it's so dilute. Here is everything you need to know about pituitary adenoma in one slide. Pituitary adenoma, it's an adenoma, not an adenocarcinoma, so it's a benign tumor. Benign tumor in the anterior pituitary gland with local mass effect that can compress the optic chiasm, leading to bitemporal hemianopia. It can compress the pituitary itself, causing hypopituitarism. Sometimes the tumor is secretory. It secretes tons of stuff. The most important or the most common is prolactin, and this is a prolactinoma. There is a genetic component to pituitary adenoma, especially in cases of MEN1 or multiple endocrine neoplasia 1. The tumor could be a somatostatinoma, secreting too much growth hormone causing acromegaly, or it could be a prolactinoma, that's the most common type, which causes increased prolactin secretion and galactorrhea, or it could be corticotropinoma, secreting too much ACTH, which is Cushing syndrome. By the way, when the Cushing syndrome starts in the pituitary, as in this case, we call it Cushing disease. Thyrotropinoma secretes too much TSH, the thyroid secretes too much thyroid hormone, and this is hyperthyroidism. Compression of the optic chiasm causes bitemporal hemianopia. Compression of the pituitary itself causing hypopituitarism. Compression of the gonadotropes in the pituitary causes hypogonadism or premenopause. Cranial nerve deficits can happen if it extends to the cavernous sinus. Obstruction of the foramen of Monro causes hydrocephalus, and compression of the pituitary stalk causes diabetes insipidus. How can I diagnose pituitary adenoma? Clinical signs and symptoms. Serum prolactin level, since prolactinoma is the most common. If prolactin level is greater than 200, this points towards a prolactinoma. But it could also be a somatostatinoma. That's why you need to measure the serum growth hormone and you do oral glucose tolerance test. Excessive growth hormone tends to raise serum glucose. It could be a corticotropinoma, so you do late night salivary cortisol level, serum ACTH, 24-hour urine ACTH. Bitemporal hemianopia, we need visual field testing. It is called perimetry or perimetry. And to see the actual tumor, and this is a very accurate test, this is the MRI of the pituitary gland. If MRI is not available, you can do CT scan. How do I treat it? If it's causing all kinds of damage and compression, we need to remove it. It's called transsphenoidal removal of the adenoma because you cut through the sphenoidal bone. To learn more about the bones of the skull, please refer to my anatomy playlist. I have anatomy review videos on the head and neck, thorax, abdomen, pelvis and perineum, neuroanatomy, upper extremities, lower extremities, and even embryology. What if there is Cushing disease and it does not respond to treatment? Bilateral adrenalectomy. Radiation therapy might help. If there is too much growth hormone, block its receptor by giving a growth hormone receptor blocker known as pigvisumant. If it's a prolactinoma, lower the prolactin secretion by giving a dopamine agonist such as capergoline or bromocriptine. If there is too much cortisol, give meterapone. To learn what meterapone does, please refer to my physiology playlist on the adrenal cortex. Somatostatin analog, which is octreotide, because somatostatin is a universal inhibitor. If you want to inhibit the growth hormone, the prolactin, the ACTH, and the TSH, simply give somatostatin and it inhibits everything. It's a universal inhibitor. If you want to learn about neurosurgery, cardiothoracic surgery, trauma surgery, general surgery, preoperative care, postoperative care, and more, download my surgery high yields course at medicosisperfectionalis.com. To learn about the types of strokes, myocardial infarction, cardiac arrhythmias, ARDS, acute limb ischemia, hyperthermia, hypothermia, detox syndromes, download my emergency medicine high yields course at medicosisperfectionalis.com. To learn about anti-epileptics, antidepressants, antipsychotics, anti-Parkinsonian medications, the opioids, the anesthetics, the stimulants, the sedatives, the hypnotics, download my neuropharmacology course. If you value what I do, help me make more videos by supporting the channel. Go to buymeacoffee.com/medicosis. There are more than 600 premium videos available on this channel when you click the join button and choose the highest tier. Please subscribe, hit the bell, smash like, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you would like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine, chemistry, math, and physics make perfect sense.